The anatomical basis of perineal lesions. In this we explain anatomical basis of perineal tear, episiotomy, perineal abscess and anal fissure. Perianal tear. There are 3 degrees of perineal tear. First degree, second degree and third degree. In addition, Jones describes a 4th degree of tear. First degree involves tearing of the fourchette skin only. Second degree tear involves the skin, superficial muscles of the pelvic floor, may also involve deep pelvic floor muscles. Third degree, second degree tear that extends to the anal sphincter. And fourth degree, when the anal canal is open and the tear may spread up to into the rectum. That is the fourth degree. Sleep et al. Claim that protagonists advocate the liberal performance of episiotomies because they believe it will reduce the incidence of both serious vaginal and perineal tears and thereby prevent long-term problems such as stress incontinence and vaginal prolapse. Episiotomy. Reasons cited for performing episiotomy are prevention of long-term damage to the pelvic floor, thereby avoiding stress incontinence in later life, and prevention of interference with sexual function. Episiotomy was first performed nearly 250 years ago for difficult births. It only became commonplace when local anesthetic and catgut for suture material were introduced. Episiotomy is a surgical incision made at the time of delivery to enlarge the vaginal opening for ease of passage of the newborn infant. Structures involved are the perineal skin, the vaginal mucosa and the pelvic floor muscles. There are 3 types of episiotomy: midline, mediolateral and J-shaped. There are many indications for performing an episiotomy that include any conditions likely to cause perineal tear: fetal distress, delay of the head of premature baby upon perineum, rigid perineum, previous vaginal repair, and imminent splitting of the perineal skin on delivery. Perineal abscess. Perineal abscess in childhood is relatively common. In adults usually follows an acute infection of the anal glands. The etiology in children appears to be due to congenital anomalies of the anal crypts that predispose to abscess and fistula formation. Schaeffer et al. Describes an abnormally thick dentate line with deep anal crypts in children with fistula in ano or perineal abscess. Al-Salam et al. Noted that fistula was commonly lined with epithelium that included stratified squamous, transitional and columnar epithelium. These support the theory put forward by Popul and Ralphs that fistula may result from entrapment of migratory cells from the urogenital sinus or hindgut during development of perineum. Fitzgerald suggested that an excess of androgens in utero could cause the formation of abnormal anal glands that predispose to fistula formation. Anal fissure. An anal fissure is tear in the epithelium lining of the anal canal. It is an extremely common condition. Anal fissure may be delineated as acute versus chronic and typical versus atypical. Physical findings include a linear separation of the anoderm. Posterior midline is the site of up to 90% of typical anal fissures. The remaining minority of typical fissures are found in the anterior midline. Typical fissures are usually in the posterior or anterior midline. In contrast, atypical fissures can occur anywhere in the anal canal. Despite common nature of this long-standing problem, the exact cause remains uncertain. Many patients relate the occurrence of fissure to the passage of a hard stool or anal trauma. There may be mechanical factors in the posterior midline secondary to anorectal angle that creates greatest stress at that location. The common finding of sphincter hypertonicity has been described. However, it remains unclear whether the elevated pressures are the direct cause of the disease or an effect. Another common theory relates to the relative ischemia at the posterior midline anoderm. This area of anal canal has been shown to be fairly ischemic by arteriographic studies and laser Doppler flow studies. The theories of hypertonicity and ischemia may be intertwined to some extent, particularly in that hypertonicity may aggravate the relative ischemia. Anal fissure, tears in the anoderm occur with great frequency, whether from large stool, anorectal intercourse, or instrumentation from surgical procedures. Fissures can occur in the absence of any trauma or constipation. May even be present in patients with diarrhea states and sphincter hypotonia. Thank you.